Good afternoon, everyone. The objective of this presentation is to discuss a quantitative research study about perceived discrimination of Muslims in healthcare and the healthcare setting in the United States. And I'd like to explain the answers to the research questions that were identified in this investigation. Now, there's an awful lot I could talk about. I did a dissertation on this, so I have to really stick to basics here for the sake of time. And my interest is really to hear from you, the audience, and have some dialogue about the situation right now in the United States and across the world with what's going on with our perceptions of Muslims and what we understand about this religious group. Just to give you some background of why this became an interest for me, I am a nurse. I've been in nursing since 1985. I'm a New Yorker. I was born and raised in Queens, and my first job was on First Avenue in the VA. And I would say that I probably never encountered a Muslim patient in my years working there, as well as also upstate New York where I worked. I do remember encountering one woman whose husband was Muslim, and I remember having some questions about some of the culture at that time. But 30 years later, I'm talking about this issue. The growth and diversity of the Muslim population in the United States certainly has grown. This is a very diverse group. Please keep in mind that Islam is a religion, and the U.S. Census does not track religion. So the estimates in the United States are between like 6 and 7 million Muslims, and culturally, ethnically, they're very diverse from really many parts of the world: Africa, the Middle East, Asia, Indonesia, and African American, to name a few. Since 9/11, there's been heightened negative influence of discrimination on health outcomes, confirmed by research, and more attention has been given in the circles of psychology and sociology and education about increasing problems around discrimination of Muslims and groups who are Muslim and Arabs as well since 9/11. So the statement of the problem from my research was really threefold, and I looked at discrimination as a healthcare disparity, which has resonated many times here in this conference. I looked at discrimination and its impact on mental health and well-being. Again, in nursing, I found this to be an important problem that needed to be addressed. And as I said, the literature on mental health and well-being and its impact of discrimination is out there. And discrimination related to lack of knowledge about culturally congruent care was a concern, and that I saw as a problem, because what I think, too, we have to remember is what may be perceived as discrimination by, say, a Muslim patient may truly be just a lack of knowledge on the caregiver's part. But again, with communication and interaction, this could be perceived as discrimination. So keep in mind, this is perceptions of discrimination. Okay. So the purpose of my study was to explore the crossover anti-Muslim discrimination from society to the healthcare setting in the United States, to explore the extent and the types of anti-Muslim discrimination in the U.S. healthcare setting, to really get specifics on this, and then to ascertain care preferences of Muslims that may guide culturally congruent care practices. To address some of the historical and social context of Muslims in the United States, immigration of Muslims to the U.S. really started with slavery. Going back to the 1500s, the first Muslims came to the United States from Africa. In the 1870s, we started having Muslim immigrants from Turkey, Eastern European immigrants, as well as Middle East and South Asian, did start coming to the United States, seeking employment, seeking opportunity. After the 1960s, political conflicts became a prevailing reason for migration of Muslims to the United States. The Iranian Revolution, after the 70s, late 70s, spurred the immigration of Iranians to our country. Iraq, there were issues around the Kurdish population and conflicts in Iraq. India, wars between India and Pakistan populations. The Lebanese Civil War that was over 17 years created a great migration of Lebanese to this country. Somalia, Yugoslavia, and Palestine. Palestinians were other groups that came to the United States. Negative images of Muslims emerged long before 9/11. That's starting back with, since 1948, the Israeli-Palestinian conflicts, and then again in '79, the Iran hostage crisis drew great media attention, where 52 U.S. Hostages were held for 444 days in the U.S. Embassy in Iran. In 1983, the Marine barracks were attacked in Beirut, Lebanon, during their civil war, and again, great media attention to this, the height of the Lebanese civil war, where many Marines were killed. I believe that the number escapes me right now, but it was well over 1 to 200, I believe, Marines killed at that time. After 9/11, in which four passenger plane suicide attacks occurred on U.S. soil, there were nearly 3,000 deaths, including 227 passengers. 19 attackers were Muslim with extreme ideology. Peake is a sociologist who wrote extensively about what she calls the backlash or the aftermath of 9/11, wherein fear, negative stereotyping, and suspicion of Muslims became rampant. Violent acts and discrimination were increasingly made against not only Arabs but Muslims, Sikh population, and any groups that really resembled what may be perceived as, the stereotype of a protege of a terrorist. The Patriot Act actually lessened the restriction of law enforcement to stop and to arrest based on any suspicions. Work visits were carried out. Bank accounts were frozen and suspended for anyone with suspicious financial activity. We all know about the travel and what's happened in travel in the United States and across the world, the type of restrictions on travel and so forth. So that gives you some background to my interest in this subject. As a nurse, there was a mention earlier that I picked up and I really appreciated from Dr. Bosch yesterday. He talked about the work and with his group in the school system, and he said basically what they're doing really relates to humanness and caring. And that resonated with me because as a nurse, the core of our work is caring. And there's a lot of literature, believe it or not, and theories written around caring in nursing. And one of them that I use to frame this research is Transcultural Caring Model by Ray. And you can find some of her work certainly online, but she started with this model in 2010. And I found this to be a really suitable model to frame this work. There are 4 aspects to the model: the essence of caring and how caring is viewed within a culture, transcultural context, which would include like our society, the backdrop, educational, political, financial, social context in which people live, ethics related to populations and views of ethics among and within cultures, and the spiritual dimension of cultures. The model appears two-dimensional, but it's actually multidimensional, and if you see the dotted lines, all of these aspects interrelate. And what I find really unique from this model to some other models is that it acknowledges the culture of not only the patient, but the caregiver as well, as a reciprocal, dynamic, moving, interrelated really mechanism in which understanding, caring, awareness, and choice can actually take place. And of course, it does take into account spirituality. The human-environment connection is emphasized by Ray, and then again, the central theme culminating in this awareness and understanding is choice in caregiving and direction of care for the patient. So my research questions were fourfold. I developed a new tool, so one question would be the reliability and the validity of my newly developed Health Care Discrimination Scale, and what extent of perceived discriminations do Muslim Americans report was the next question. What extent of perceived discrimination do Muslim Americans report in the healthcare setting? What are the types of discriminatory behaviors Muslim Americans report in the healthcare setting in the United States? And finally, really, from this, we wanted to elicit preferences through this survey that Muslim Americans may have, and how that could guide the care considerations in the healthcare arena. When I went to literature review, it was pretty limited. They were mostly the employment, education, airline industry, and healthcare setting, but there were not really many studies. It was more, there was a lot of literature just about kind of what was happening and perceptions about how people feel, or some experiences that were made, that they went through, and lawsuits that were found to have occurred in the education settings and these other arenas. When I looked at some of the legal issues that were being written about were civil rights violations, abusive remarks, problems related to Islamic clothing, for instance, in the employment setting, prayer rituals, and Islamic holidays even in the workplace. So those are some of the resounding messages that came across in the literature. But when we went to the research, there were really about 17 studies, and they weren't really all about discrimination, but I had to really take what was out there and see what was even some of the studies about experiences in the healthcare setting or the employment law and education setting. So 5 of them were by qualitative, mostly descriptive, and then there were 10 quantitative studies, but none of these studies really had a tool to address discrimination in the healthcare setting. So the gaps in the research were certainly the lack of a theoretical framework. There was just one study that had mentioned like a medical model about culture, just very briefly, but nothing to the extent that I provided in the study. And there was a limited scope of sample. Many of those studies were done just in regions like Michigan or California, New York, etc. So there was no national sample. And there was also a lack of instrumentation, as I said, where I could really see what were the extent and types of anti-discrimination measured in the healthcare setting. So these were the items I wanted to bring to the research. For the sake of time, I won't go into all the methodology, but the integrity of the research process was certainly kept, and I had an IRB and consent forms, and explained the benefits and risks of the study to the participants. So if they felt upset in any way, they could just stop proceeding with the study if they found, for instance, that it was too upsetting. The inclusion criteria was over 18, living in the United States. It was pretty generous. And in terms of being an adult, they really did have to speak English because of the method that I used. And so that was about it. I originally actually contacted mosques and organizations in Florida where I was living at the time, and I was not getting the reception that I wanted, so I sought out like a national Muslim organization across North America, and so it really started to become snowballing from that, as well as I went into Facebook, and in order to keep my participation going, I did use Facebook, and actually that worked out pretty well. I went into Muslim organizations or organizations that appeared to have a Muslim, interest, and then I would email them and send them the survey and so forth. And I also did a few paper surveys. It was very limited in number, but there was a thought that, that I should try to do some paper surveys, but it's very cumbersome, and I think just actually talking to someone face-to-face about discrimination, especially being Muslim, was not something that I found to be people were not receptive to doing at all. And in fact, when I did have the paper surveys, they just really took them home and then gave them back to me later on. The plan for data analysis, I had a socio-demographic questionnaire with 9 items of all those items up there. And then I had an established tool, the Perceived Religious Discrimination Scale, that was developed by a psychologist that really looked at discrimination, anti-Muslim discrimination. And the Health Care Discrimination Scale I developed, and it was based upon 2 aspects of information that I was able to ascertain from experts in cultural safety. So I looked at I developed 6 items related to issues around cultural safety, like feeling safe, feeling like your identity is respected, and so forth. And then the other 6 items related to healthcare preferences. And then I had 3 open questions. One was like a yes/no, if you felt like you were discriminated against. The next question asked the participants to list the types of discrimination. And then I had a rank order of care preferences, and some of these items were developed from the literature review that I did. So the tool that I used to look at discrimination had already established validity and reliability. It had high alphas from two previous studies. My tool that I developed, the HCDS, I did face validity. I did a CVI content validity index with experts in the field. It did come across kind of low at 0.5, so that's an area that I could revisit to improve some of the clarity of the questions primarily. It was more about the readability and clarity of the questions. I did a construct validity, but actually the factor analysis was not done. It will be done in the future. And I looked at concurrent validity and also looked at the external validity and some of the aspects of that. So one thing I want to say about the results, and you can access this, this publication. It's, if you just Google my name, it comes up as a PDF through ProQuest, like my dissertation. I will be publishing it soon. But it's interesting to note that I had 334 people access the survey online, and over 100 didn't even proceed. So I think, that's a question. Why did they just stop at that point when they saw that the questions were asked? I mean, I can say in my own mind, I think it has to do with, asking about discrimination, being Muslim, you're suspect, and I'll talk about that some more, but that's an interesting number right there, that, the point is not working, but, why did we lose those people, 334 to 219? So I did have some paper surveys. So when we look at the results, the sample, now with the sample, I had 227 answer all or some of the survey. There was missing data. So if you look at my ends, they are really addressing the items that were responded to. So I know I've been asked about that in the past, but that's how the statistician wanted to do it, because we didn't want to lose data. We didn't want to throw out partially completed surveys. So the average age was about 38. The years of education was high, almost 17 years of education. This was a highly educated group. And you have to remember, most of them were accessing on the computer, so that's something to keep in mind, and certainly a limitation. So we had almost 61% female and almost 40% male. Most were married, almost 70%, almost 25% single, never married, and 6% almost divorced, separated. Most were employed, 67.9, 28.4 unemployed, 3.7 retired. Now this is interesting. The ethnicity, just picking out the main numbers here, Arab was identified as the largest group, 30.8, Pakistan 14.4, let's see, Eastern European 12.8, Indian 10.6, and African American for this sample was 6.4. So just keep that in mind. And again, it goes back to starting, I think, with the local mosques in Florida, and then statewide with the mosques, and then I just wasn't getting the reception that I needed, and then I went to a national sample. But a lot of it, started with mosques, and so the study could be replicated in other cities, and we could look at that with the African American population. Of those born in the United States, 44.5 yes, 55.5 no. For those not born in the U.S., the largest percentage was Pakistani, from Pakistan, 8.4. Let's see, India, 4.2. Palestine, 3.7. Egypt, 2.7. Algeria, 3.3. And so on. So really the largest group and the largest group really were the Arabs, secondly Pakistanis in this sample. The income, you can see, was really quite high. If you look at those central columns there, 10,000 to 50,000, 50,000 to 100,000. Those three columns, they make up more than half of the sample, almost 60%. Of the use of Muslim clothing, 62.6 said yes. And remember that this is a predominantly female sample, and the hijab was the #1 type of clothing used, reported. It's 37.4 no. So in answering my research questions, I established the reliability and validity of the newly developed scale. The PRDS is a scale that was already established, so I really came in with a good alpha on that one, almost 0.95, so I was very happy with that. The new scale that I developed, it was pretty good at 0.78. If I break down the scale between the two subscales, they were different. One was 0.87, 0.662, but pretty good for a first time, run of the scale, so I was pretty happy with that. Looking at the assumptions of parametric statistics were met, the mean, the mode, etc. The inter-item correlation was fairly strong for a new tool. Overall, the sum is actually the whole tool together, the 12 items. That was actually on the lower side, 0.3, but one half of the tool came in pretty moderately correlated. So again, this would have to be looked at again for improvements in the scale that I developed from this point of view. The test-retest was actually the result was good on that, 0.984. So that refers to participants that I did a small group of participants that took the survey, and then they repeated the survey, and most of their scores were the same. Concurrent validity, there were significant findings. The validity across the concurrent validity, across all the scales was significant. So they were all well correlated. My second research question: what extent of perceived discrimination do Muslim Americans report? The two scales, the previous established scale, it was possible points from 0 to 132, so the higher the points, the more discrimination, and the same with the scale that I developed, the HCDS. So the mean for the PRDS was 61.7, and the mean for this tool that I developed was 20.45 out of a highest score of 48. The yes/no answer was responded as such. 72.4 participants said no, they do not perceive to be discriminated in the healthcare setting, whereas 27.6 said yes. So almost 1 in 3 of this sample felt they were discriminated against. And this is very telling. The number one type of discriminatory behavior that Muslim Americans reported was feelings and perceptions of being excluded and ignored. And I think this is, telling of the sense of otherness that this group feels in the public arena. The number 2 was feelings of discrimination related to Islamic dress, offensive remarks, Islamic holidays, and prayer rituals, and even physical assaults. Some of the other findings that came about in my study, let's see. Education and discrimination were negatively correlated. So those who were higher educated had lower scores of discrimination. However, age was positively correlated with discrimination. So older individuals in the sample felt more discrimination. Okay, there were no real significant differences between gender or being born in the U.S. or not. And actually, with wearing Muslim clothing, the scores were higher for the participants who wore Muslim clothing than those who did not, but they were not statistically significant. And even though it was a small number, only 8, there was no statistical difference between electronic and paper format of the survey. The fifth and last research question related to the care preferences. This is a bit complex to put in a graph, but what I want to pull out of this is in order of preference, most of the participants felt that the same-sex caregiver was the most important preference to them in the healthcare setting. So female caregiver for a female, male for a male. The second most important preference was modesty. The next, privacy. The next, dietary considerations. And the next, family involvement. And finally, prayer. Something that came about very unexpectedly during my research was the Boston Marathon bombings. And this I found to be very significant and related back to the theoretical framework that I used. And Ray talked about context, to consider context in any transcultural and cultural analysis and relationships. And the scores reported, the bombings actually happened during my data collection, and the scores of perceived discrimination were higher after the event than before the event. So on actually both tools. Some of the things I want to mention about discussion, the findings I've hinted at as we go along. What are that this is one sample, but we can look at this issue of otherness. I think really resonated in my findings about being excluded and ignored in the healthcare setting. The limitations within the study, it certainly was limited to a convenience sample, and the findings cannot be generalized. It did not capture non-English speakers, so language is something to really consider with this study. And those who did not, have access to computers, that was a limitation, even though I did have some paper surveys. But I will say, I'm convinced that after my experience with this, that paper surveys are really not very helpful with this and really not practical. I had a school in Florida that I contacted before the Boston Marathon bombings that they were willing to fill out paper surveys and have me come and have all their faculty fill out the survey. It was an Islamic school. And the day after the bombings, the principal called me on my cell phone and said, Mary, I'm sorry, none of us want to do this, so please don't come. We feel very upset about what happened, and we feel that she used the word paranoid, that we might be tracked or something. So they pulled out of the survey. And again, I have to think back to those over 100 people that I lost in the survey when people started to see the questions that were being asked. So I think it's difficult to do a research study like this and really get large amounts of data. Another limitation, this was only the patient perspective. There is some very limited literature about staff perspectives after 9/11, Muslim nurses and how they felt and some of their experiences. So it would be interesting to see from a provider point of view if there's obstacles to really care between providers, that if patients don't want a Muslim provider. And I had heard of that. Some of my colleagues, actually, their patients wouldn't go to them any longer after 9/11 because they were Arab. The new instrument certainly would need modification. And the other thing that I did, one of the strategies for data collection was I elicited an organization called CARE, the Council of American Islamic Relations, and that in itself could be a limitation because I actually did this presentation in another arena, and when someone in the audience heard that I had something to do with CARE, she told me she wanted to walk out of the room, and in her eyes it just discredited my work because of any information from anybody related to that organization. It's a bona fide Muslim advocacy group, but there, like many advocacy groups, there's been some negative reports about them, and anyway, but that was just something that I did have to mention as a limitation in my study. Okay. So implications, really the resounding implication for me as a nurse in the clinical setting, and one of the impetus for this research myself, I spent like 7 years in Saudi Arabia, and I came back, it was after 9/11, and I really did see a big, shift in the politics here and the media and all of that, even though I was aware of what was going on overseas, to work here and see in the clinical setting a huge, lack of knowledge about the Muslim population, and not only lack of knowledge, but also prejudice and stereotypes that have already been established. So I really felt, I wanted to ask the question, what's going on, in the healthcare setting for Muslims. So really, my resounding, attention after this was, what about federal policy about civil rights, the Civil Rights Act, and enforcing that in the healthcare setting, and as well as some of the standards that are in the healthcare setting related to patient rights and language and cultural respect and so forth. Implications for political sciences, I'd like to really see more interdisciplinary research, because again, I think this conference reinforces the great potential for research among the disciplines and how much we're learning from the fields of education and psychology and public health. So really to pick up and do more of that. And for practice, we're in a never-ending, quest for cultural, competence, which I really don't like that word, but the ongoing awareness, and it really starts with self-reflection, and education about cultural understanding and heightened sensitivity to the experience of Muslims in the clinical setting and the prevailing socio-political environment that they're living in the United States. And when there's negative political occurrences, and we've even seen it since I did this research, now all of the media attention to ISIS and what happened in France and, hate crimes, so forth, what just happened in the Carolinas. Every time something like this happens, it gets harder for Muslim Americans and I think Muslims around the world. And I don't think you have to look too far to see some of those reports. It's all over the news. All right, and again, just as from a nursing perspective, we would have to be more aware and medical perspective of some of the care values that Muslims have. And again, remember that this is a very diverse group. I mean, there may be plenty of Muslims that don't pray or may not show any interest in their, religious rituals when they're in the hospital. So we have to really remember that, yes, I reported some of this data, but within that data, there's also the fact that prayer was maybe the last thing of a preference for some of the people who responded in the survey, whereas for others it might have been the first thing. So keep in mind, like many cultural groups, that this is a very diverse group, and we have to really look at the individual and leave room for acculturation and individual experience. Just getting back to Ray's model, if you have interest in that, we talk a lot about negotiation in this conference, and this is a culture value conflict assessment tool, and you can find this on Dr. Ray's site. But she does a nice job really identifying all of the different aspects we would really want to consider in our patient and caregiver interactions that not only to reflect on the patient, where the patient sits with all of this, but ourselves as caregivers, and really self-reflect on that, and where we might have to negotiate. So, recommendations for research, for further research, I would want to definitely refine, make shorter the whole thing, because I think that was a problem. It did kind of become cumbersome with like 48 items. Do a factor analysis and possibly adapt to other groups. And one thing I found in doing research and my literature review was sometimes in the literature, like discrimination is widely talked about, but what are the types of discrimination? There's not as much on religious discrimination as there is on racial and ethnic discrimination. And Muslims this is a religious group, but within that there are also racial groups and ethnic groups. So it's a complex group to do research on. Okay, and again, just interdisciplinary collaboration between healthcare and the social sciences, because as we do see, almost 1 in 3 Muslims in the healthcare setting feel they've been discriminated against, but on the other hand, maybe 2 out of 3 don't feel that, and so I hope we're making progress in the healthcare arena for being more culturally sensitive, to patients. So, thank you. I just want to open the floor to questions. And there's my email. I'm very happy to hear from anybody that would like any information. Any questions? Yes, please. Do you want to use the mic? Yeah.
Hi. Thanks so much for your presentation. I really like how you talked a lot about setting up your survey, and I'm wondering if when people opened it online, they saw the whole thing, or was it just the first question and then maybe next?
Okay, great question. I should have said that. I used SurveyMonkey, and I actually created it myself, and so they only saw one question at a time.
Oh, okay. I would assume that if they saw the whole thing, maybe that would prevent them from wanting to do it.
No, they didn't see the whole thing. Well, actually, it wasn't like, it didn't appear as just one item only, but like a few would appear, and then they'd have to go to the next one. And actually, I think they had the ability to go back. But you can set that up. Right. You can set it up whichever way you want.
Okay, thanks.
Yeah. Okay, thank you. Anyone else?
I also have a question about your survey. With your ongoing research in this population, do you consider to work with people who may be able to translate into the actual language that your population might speak? Are you interested at all in doing in-depth interviews so that you can further understand maybe the types of discrimination that they are actually experiencing? Because you might assume that these are the type of things that they might be experiencing, but if you hear it from them themselves, you might be able to put it into survey questions that they might be able to be more prone to.
No, you raise a great point, and I think I'm still kind of deciding the next step to go. I did mention some of the implications for further research, but right now I'm teaching graduate nursing, and I mean I have the opportunity to have dialogue with students about culturally congruent care. But as far as actually taking this tool, I could see going in a couple directions. I could refine it based on the Content Validity Index. I could refine it based on some of any comments that I've gotten along the way, and I could give it another go. Because I really have a lot to work with in terms of refining it. On the other hand, I think it would be really good to have some focus groups and really look at the wheel of research and maybe do another quantitative and then go into more qualitative with focus groups and see what I get out of that, and then maybe present that and look at those findings and see then if I could use that to refine the tool. So as you know, there's the cycle of research could go on. The other thing is having more of an open-ended opportunity for them to put comments on a survey. If I could make it shorter, that I could increase some of that, so pull out some text, from this. Yeah. That was just, the length was difficult because I kept the PRDS intact. It was 33 items, and it was actually done by a psychologist who looked at Muslims in the United States who, and how they felt about, after being in Iraq and the Gulf Wars, when they came back, how they self-identified with, the enemy and so forth. But it also addressed discrimination. It's very interesting, actually. And prior to that, the tool was originally created for Asians, and again, on veterans. So it was vets who served in like the Vietnam and Asian wars that came back home to the U.S. and how they felt to be perceived because they resembled the enemy and so forth. Yeah.
I just have a question about I guess what did the participants get as a result of participating in the survey? What did they get to benefit?
Actually, you raise a great point, and this was talked about a lot when I was working on this. And personally, I did not want to do anything like, gift cards or anything like that. I know some of my fellow, doctoral students at the time were doing that, and I didn't really feel that was the right thing to do. And when I wrote the instructions and kind of the little introductory letter, I said, you will really, the only benefit from participating in the survey is that you will gain, have knowledge that, research is being done to hopefully address the needs of the Muslims in the healthcare setting, and to hear what those needs are or aren't, so to contribute to knowledge. And I don't think people really see. I didn't have any kind of comment or any interest in what am I getting. That wasn't it. I think the more concerning question was, if I fill out this survey, will I be tracked, or will I be known, and so forth. Yes.
Good afternoon. I encountered a Muslim family in one of the clinics in East Harlem when I worked as a health educator there. And I was working as a cancer health educator, but I noticed when I spoke to the wife about the cervical screening exam, the wife didn't answer. Her husband is the one who responded.
Sure.
So I'm just wondering, in some of those who maybe just opened the access to your survey and chose not to respond, is it because they were not allowed to respond to it, to your survey? I mean, you won't know, but
Yeah.
I just, as you mentioned that, I was reminded about that.
Yeah, thank you for that. And the brief version of my answer to that is, in public, in certain cultures where, who are Muslims, there may be respect given to the head of the family, the male figure, to be the voice for the family and be the voice for decision making. With that said, and I did experience that. I experienced that 30 years ago in the VA with the very only Muslim family I ever took care of at that time. The husband was quite demonstrative in what he wanted, and the woman didn't really say too much. My personal experience is I've lived in the Middle East for 7 years, and I've been to many, many Arab countries. Within the household, women are very strong and very decided and very vocal. So I don't want that to be a misconstrued perception that men make all the decisions. Okay, this is somewhat off the record. On the other hand, I think we need to appreciate that decisions around health, and maybe in that circumstance, if there's something that is related to reproductive health and so forth, that's something that, this particular individual, this husband wanted to be involved in. We have to be careful not to generalize, but you will see that, and you will see that. I have no doubt you will see that. But I think it's very culture specific. It's also related to the education of that couple, and where they are in that whole arena of decision making and autonomy within their relationship, and that will vary among individuals. Yeah, I hope that answers your question. All right, I know my time is up, so. Thank you for your attention. I think we're going to have some more time for dialogue after the next presentation.
Hello, everyone. Hi. So this is really loud. My name is Dayle Hodge. I'm a fifth-year MD PhD student at the Albert Einstein College of Medicine, which is located in the Bronx. I'm here today to talk about health problems in urban communities. I first gave this talk a few months ago at the Borough of Manhattan Community College, and the target audience, obviously, are community college students. And the idea was just to really give them a sense of the problems and health problems in urban communities today, and also to give them the historical context. You have to think about a lot of the students in community college now are probably born in the early 90s, so they don't have a context for a lot of the things that have happened. So first things first, I want to sort of give this to, oh, here we go. I wanted to really start out by talking about health disparities and start off with the whole historical context, because a lot of the problems you see today are rooted in decades and decades worth. Basically, it's been in the works for decades. And one of the key metrics that I look at is sort of life expectancy. That is an easy way to sort of start this, is because it's very stark. I gotta start it that way, and also. People can really wrap their head around it. They know how long people live for. So to really understand the greatest differences in how we live, we have to see basically how we die. And that's where I'm going to be starting this. So the top 10 causes of death in the United States, and I'm breaking it down by pretty much different racial groups. So. And also, let me just say, before I started off medical school, I didn't even know there were like 10 ways to die. So you'll have to sort of bear with me. I can understand if you run out of like ideas after like number 4. So let's go from there. So number 1, what's the number one thing? And this is even though this is for white population, this is sort of true of the general population. Heart disease. Okay, number 1. That's about a quarter of people. What's next? Cancer. Good. All right. I'm waiting until you guys get to like 3 or 4, and I was like, So diabetes is up there. It's not number 3. Number 3 is respiratory disease, like COPD. Number 4, stroke. Stroke. So you see already there's a similarity between number 1 and 4. They're both vascular diseases. So that sort of gives you an idea of sort of lifestyle habits that you see. Number 5. Accidents. Good job. So most of these accidents are vehicular accidents, usually car accidents, about 30,000 every year. Number 6. No one ever gets this one. Alzheimer's. Really, yeah. So this is increasing over time as the population ages. You're getting to, and really, if people ask like, how do you die of Alzheimer's disease? And there are a lot of downstream ways. I'm not going to get into it now, but just know that this is actually an increasing prevalence in our society. 7. Diabetes. Good job. You can't answer. You know this already. All right, so diabetes, and we're going to get back to that because that's a really important point to seeing the disparity in that particular disease. Flu, a lot of people wouldn't think of that. Number 9, kidney disease, which is also related to diabetes, and number 10 is suicide. Okay, so that's for the white population. Let's move over to the Hispanics. So right away, you should see a couple things that sort of pop out in your mind. Are there any stark differences that you can see off the bat? Accidents, all right. So there's about a 50% difference there. Why is that? I don't know. That's something that actually I thought about. I looked into literature and say it again? So labor force is part of it, actually. I looked in literature, and because there are a lot of more migrant workers, especially working on farms, there are farm accidents. Also looking at, they saw a correlation between socioeconomic status and the ability and the willingness to wear seatbelts. So there was a slight correlation there. But yeah, accidents, that's something that I was shocked when I was doing this research. One other thing that sort of pops out right away. Liver disease, exactly. And I'm not highlighting that here, but yeah, definitely. That's not even on any of the other lists. And that's I don't know why. I mean, there are a couple of things. Actually, part of the reason why is because of different liver enzymes that are more prevalent in Hispanics. Actually, when I looked into the literature, there wasn't actually a larger prevalence of alcoholism in Hispanics compared to the white population. So a lot of that is genetic, but part of it is also habit. The one thing I wanted to point out here is diabetes again. So you can see there's about, I want to say, an 80% difference between the two, and that's something that you would think that, I mean, people living in the same cities, same kinds of foods, why would there be an 80% difference between these two groups? So we'll get back to that. So next thing I want to look at is the black population. So again, any kind of difference you can see here right off the bat. Diabetes. So again, you're seeing like a 75% difference between blacks and whites. Yeah. Well, don't get there. We'll get there. No. Okay, yeah, we'll get there. We'll get there. There's a whole. Can't ruin the whole show. Okay, so this brings me to the next point: the effect of the environment on disparity. So, looking at type 2 diabetes. Type 2 diabetes has a prevalence of about 8% of the population in the United States, which is crazy. You're thinking about 1 in every 10 healthcare dollars is spent. Actually, 1 in every 9 is spent on diabetes care. So, it really is a huge economic impact. And looking in the United States, again, you can see that there's a great disparity. If you're looking at, especially in the Bronx, and this is, as a medical student in the Bronx, I see a lot of, these issues, is that, there's about a 50% difference between the rest of the population in the Bronx. And I'll get into that later. And also, like I mentioned, this is a huge economic impact. If you're looking at New York City alone, you're looking at it's about $7 billion a year. So why is that? So On the left-hand side, you can see there is a map of New York City, and in the shaded areas, you can see the areas that have high supermarket needs. And how do you define high supermarket needs? And the technical breakdown of it is that you need a supermarket that's 50,000 square feet at least. That's within 8 to 10 minutes driving of 10,000 people. So to make that easy to understand, you just need a lot of supermarkets for a lot of people. But the problem is, especially in New York City, space is at a premium. And it's not like the case elsewhere in the country where you have big, wide supermarkets. I'm from upstate New York. We have Wegmans. You know Wegmans? Yay! So those largely are absent in New York City, just like I said, because space is at a premium. What I thought was interesting here is can you see the laser here? Is it working? Here we go. Can you guys see that? Okay. So you notice that we can see high rates of supermarket need almost coincide exactly with diabetes. So it's kind of crazy to think that. And what I really want to point out here is that the areas that have the highest amount of diabetes are actually right next to the ones that are the lowest. You can actually map it down to the street. Like, I think that's 110th Street right there. Which is crazy to think that there's such a stark difference. You can see the highest rate of diabetes, and then you can walk a few blocks over and have one of the lowest rates. And socioeconomic, obviously, breakdown has a huge, huge part in that. So access to fresh foods correlates almost exactly to diabetes. It also kind of depends on your definition of food desert, but about 750,000 people in New York alone live in food deserts. 3 million people live in areas that are hard to get fresh food. And like I said, a lot of supermarkets have been closing recently because basically the price of the land to put the supermarket on is too high. And basically as your profit margins shrink, you can't stay in business. But what are we doing to sort of combat this? Have you guys heard about the Green Carts program? So the Green Carts program, it's like these mobile carts that allow you to basically buy fresh fruits and vegetables, and they tend to serve primarily in areas that are underserved. So what you can't find in your local sort of corner store, you can find in these mobile carts. And then also there's the Health Bucks program. You guys know about that? So basically, for every $5, for those who are use EBT, for every $5 you spend, you get a $2 coupon at farmers markets, which is great because I know, especially in the Bronx, right next to Jacoby Medical Center, where I go to school, I think every Tuesday there's a farmers market that's right there. So it does allow for access to fresh foods that people otherwise wouldn't have. Okay, so moving on to environment. What is this? It's smoke there. Or what is it coming from? A truck. Okay. So why is this important? Why would this play a key role in healthcare and health disparities? All right. So what I think what you're saying is that I can barely hear you, but I think what you're saying that the prevalence of major roadways in urban areas, right? Okay. So, and that's exactly the point. How many people have you drove here today? You did. So did I, you know. So if you ever drive on and again, I use the Bronx as a case study because that's where I live. The Cross Bronx, which is I-95, is, say it again? It's terrible. It's actually, I want to say the fifth yeah, besides the craters, it's the fifth busiest highway in the country, and the George Washington Bridge is the busiest bridge. Exactly. It's exactly. It's a major. It's the busiest bridge in the world, and because of it, it's a main artery into New York. You have a lot of diesel trucks that are coming into there. So you see this, the soot goes up, but that doesn't just go away. It actually lands not too far away from when it goes up, within a couple miles actually. And I like this graph a lot, and the reason why is because it shows such a stark difference of what location does in terms of certain diseases. So this is looking at is the rate of asthma emergency department visits in downstate New York. So if you're looking at, and the reason why I like this is because it juxtaposes the areas immediately next to New York, in like the 5 boroughs, and then and then basically the outlying areas. So if you look at the red line there, that is the New York State average. So if you look at Westchester, you look at Long Island, they're well below the average. But if you look at the city itself, you're seeing huge amounts of disparity in terms of asthma ED visits, especially in the Bronx. In the Bronx, you're looking at how many times more than the New York State average, over double. And that's a crazy thing to think about. If you look at the diagnosis rate of asthma amongst children in New York City, I want to say it's about a 3 to 4-fold difference between blacks and Hispanics and white populations. And that's largely due to things like proximity to roadways. So this next figure I'm going to show, and it's kind of hard to see. I want to focus more on the right-hand panel. You can't see it all that well, but this line here, that sort of line that creates a border, that's the Cross Bronx Expressway. That sort of defines the border in which you can see a lot of these asthma cases. And as you get farther into the South Bronx, you can see that where there are areas that are zoned more industrial and they're more areas of pollution, the rates of asthma tend to increase significantly. And also, I mean, and like I said, the Bronx is primarily black and Hispanic. So that adds to that whole disparity of diagnosis of asthma. Just to give you an idea of how bad it can be, I want to say half of K through 8 students are within about 1/8 of a mile of some place that's zoned industrial. So you think about it, if you're in your school and that the ambient air that you're breathing is actually not too far away, within 2.5 blocks, something in zoned industrial. And I want to say even more, even closer, within 500 feet of a major roadway like the Cross Bronx. So, and that people think, okay, kids have asthma, I have asthma, it's not a big deal, but that actually has a real tangible effect in terms of absenteeism, of cost, cost of doctor visits, cost of driving your kid to school and having to go back and that sort of thing. It actually has a very big measurable effect. So, like I said, air quality has a huge effect on urban environments, but there are things that are being done to combat it, and one of them is new emission standards. I don't know if you heard a couple years ago, I want to say by 2017, or I want to say 2020, the fuel efficiency standards will change so that your car has to basically double the amount of distance it gets with the fuel. And that actually, again, has a tangible effect. This is printed from about a year ago, but they think that it's estimated that with the new emission standards, it'll save about 2,000 lives per year and about 50,000 cases of respiratory ailments. So again, this simple thing like just changing regulation can have a huge effect on health disparity. So back to the list. I know I said I would come back to it. So there's one thing here that isn't like anything else, and like someone else said it before. Can someone see it? Septicemia, that's true, but right above that, homicide. Think about that. That's the 8th most common way that blacks die. And to put it in comparison to other races, if you look at for whites, it's number 22. For Hispanics, it's number 11. So you're looking at about a 600 to 900% difference in terms of the prevalence of homicide in minority communities. The question is why? Does anyone have and this is where I'm going to go into the historical context. What has historically caused a lot of violence in minority communities? So let's all of the above. All right. So let's start with drugs. And one key thing here. And again, how many people drove here today? A couple people. All right. So I jumped the gun. So I'm going to look at social policies and effect on disparity. So this lecture is sort of based around. I'll get back to the drugs and the effect on homicide, but the lecture here is sort of built around this graph. And what you're seeing is here is life expectancy over time. And naturally, as you get more medical advances and increases in quality of life, people tend to live longer as time goes on. That's pretty normal. But there's a problem here. You can see that everything tends to trend upward, except for around mid-80s to around mid-90s, the black lines tend to fall off. They sort of plateau. And that doesn't really look that much like anything. But if you actually plot the difference between blacks and whites, this plateau, when you subtract it away from this line, actually looks like a spike. And I just came across this. I'm a research mentor for a program at Einstein called the SUMP program. And my research mentees were looking at this, and I looked at it, I was like, wow, like one of the things I really like about statistics is it tells a whole story here. What you're seeing here is like the fate of an entire race. The fact that what happened between 1983 and the mid-90s that basically altered the natural progression of how people live to the point where you can see they're living about 2 years less overall from what before, less than their white counterparts. So again, I'm looking here at I use 1986 as a benchmark for a lot of this talk. So what happened in, again, the mid-80s that really took a toll on minority communities? Right, so you touch on a lot of different things, but one thing I really want to sort of touch on is this. So, look, I was saying, how many of you guys drove here? I drove here, so I pass this a lot. I pass this every single time I come to the city. And what it is, it's a mural. It says, "Crack is whack." And something you notice here is the date, 1986. So this was really at the peak of the crack epidemic. This was when things were getting really bad. And I was 2 years old at the time, so I didn't really know about it, but from what I heard, it was pretty bad. Oh, am I dating myself? So, sorry. So the reason why I want to point this out is because, again, this was the peak really of the crack epidemic, and the reason I say that is because if you look at, I like this stat a lot, is because you can see before and after 1986. If you look at cocaine-related emergencies in 1984 to 85, about a 12% increase from year to year. However, from 85 to 86, 110% increase, more than doubled. And then from 86 to 87, it almost doubled again. So it really goes to show how really bad this environment was at the time in terms of what this did just in the ED. That's people who made it to the ED. So next point I want to sort of shift gears is looking at basically the drug itself. And part of the reason why crack was so influential is because it was cheap. It was really cheap. And the street prices here, I mean, these are our estimates, but you're looking at something that's, it's more pure and it's super cheap. And the part that made it really dangerous is sort of what they call in medicine is the method of distribution. You tend to sniff powder cocaine, you tend to smoke crack cocaine, and the onset for powder cocaine is about 20 to 30 minutes, where for crack it's under 1 minute. So really you're getting a much more pure rush more quickly, but then it goes away quickly. So that's sort of what people thought was what made it more, quote unquote, more addictive. It actually isn't significantly more addictive, it's just that the rush of it initially made it seem so. But going back to the statistics, what I was saying about homicide is that it was estimated in the late 80s that about the crack cocaine contributed to about 1/3 of all homicides, and that it was 60% of all drug-related homicides. So really, it gives you an idea of how influential this was. So going back to this graph, 1986, what else happened in this time that ties into to the crack epidemic? AIDS? Well, we'll get there. One more thing. What's one thing that if you're taking drugs, if you don't die, what is one thing that can also happen to you? So incarceration. So again, I keep mentioning 1986 as a, I mean, I'm sure other good things happened in 1986, but this was really, really a life-changing year for many people. So again, if you're looking this is data that goes back, you know, to the 1920s, and for the most part, the incarceration rate was fairly constant until around 1986, and then it goes exponential. And like I was mentioning before, basically there's a certain demographics use certain drugs, or have classically. So powder cocaine was seen more amongst white communities, whereas crack cocaine was seen more amongst minority communities. And you know, I'm gonna show basically a stat as of a couple of years ago, but that incarceration rate was preferential to certain communities. So if you look at the male prison population, about 37% black, 22% Hispanic, 32% white. And in parentheses, that's how much more than it is compared to the rest of the population. So blacks are only about 13% of the population, but they're 37% of the prison population. It's almost 300% more. Hispanics are about 17% of the population, but they're 22%. It's about almost 30% more. So again, you're seeing that just this one drug in itself is causing more interaction with the prison system amongst certain populations. And that's a point I want to sort of get to later on, is prison in itself is a factor of a negative contributor of life expectancy, I should say. All right, so you guys don't have to read through all this, but there's one thing here that drove this spike here. So you're seeing this line here go exponential. What drove it? And it's this policy, the Anti-Drug Abuse Act of 1986. Now, you don't want to actually read this whole law because it's really long, but I was able to parse out some of the major points here. And this is the part when I read it, I really couldn't believe it. I knew that it was bad, but this is really, really bad. And the crux of it is this. If you are going to go to jail for at least 5 years if you have at least 500 grams of powder cocaine, or powder cocaine is seen primarily more in white communities, or 5 grams of crack cocaine. Let me just repeat that for a second. 500 grams of cocaine, and then 5 grams of crack. You can walk out with a pound of cocaine. That's what 500 grams is, a pound of cocaine. Or you can have a few pennies worth of crack, and you're going to jail for the same amount of time. That's a 100-fold disparity, and it's written into law. So really, that's what drove a lot of this. You want to see why this graph, you know, took off the way it did. It's because the law made it do that. So again, and one thing I just didn't notice, also it says heroin, only 100 grams, seriously? Like, first of all, that's a lot of heroin. But you're comparing that to only 5 grams of crack. So I just, from a physiological standpoint, to me that was crazy. Anyway, one more thing, and the point I'm driving towards is the interaction with the prison system. So on 42% of all drug arrests, and that's all drug arrests, are for possession of marijuana. That's not trafficking or dealing, that is possession of marijuana. And possession closely correlates with use. So here we're looking at data looking at the use of marijuana between whites and blacks. And there isn't really a significant difference, within a few percentage points of each other. However, the arrest rate is starkly different. About 370% difference. Now, I don't think blacks are using 370% more marijuana than whites, but, I mean, I'm a little skeptical. But that in itself drives home the point that it basically makes them interact with the prison system more. And the point I'm trying to get to is that prison will shorten your life. And if you're having a certain population going to prison, you're going to shorten an entire, basically, life expectancy of an entire community. So this is a study from Washington State. It's looking at basically the overall death rates of the general population, which you can see in the dotted line here, and then the incarcerated population in red. So actually, if you go to prison, you actually tend to live longer initially while you're in prison. But what you see here is the weeks after release from prison. And you can see that basically in the first 1 to 2 weeks after you get out of prison, you are dying at a rate about 13 times faster than the rest of the population, or 13 times more, I should say. And that continues on and on, in perpetuity. So your overall rate, even just having gone to prison, your death rate is about 3 times higher than the rest of the population, just having gone to prison. And to really give you an understanding of this in a more concrete fashion, this is looking at New York State. And you don't want to go through this entire table because it's pretty much the same thing. But the one thing I really want to harp on is that for every year you go to that you spend in prison, your life expectancy is reduced by 2 years. So you go to prison for 2 years, 4 years down. You go to prison for 4 years, 8 years down. 5 years, 10 years down. How many? And you remember the law said it's at a minimum of 5-year sentence. So you're looking at people who have mandatory minimum sentencing that probably took at least 10 years off their life. So again, this coupled with the fact that it's preferentially affecting certain communities can cause an entire life expectancy rate to drop off. So like I mentioned, the crack cocaine epidemic had a huge negative and still lasting effect. And the drug arrest patterns tend to contribute to that. But the main thing I really want to get to is that we are doing something about it. The Fair Sentencing Act of 2010 actually has started to reduce that. Before it was a 100 to 1 disparity. Now it's about 18 to 1. So it's not what it should be, but it's a step in the right direction. Okay, so back to the graph. What else happened? And to speed things up, someone already mentioned this, but what does this say? Right. So this is one thing I like about statistics is that you can sort of tease out certain details without even. This is actually basically the first introduction of HIV to the world. It was back in 1981, and it wasn't HIV they saw. It was this really rare cancer called Kaposi sarcoma, which is one of the basically what you see in advanced stages of AIDS. And they saw it in 41 people, which is odd because it's super rare. It's like 1 in a million people get Kaposi sarcoma. So for 41 people to get it, you should have a population of like 60 million people. The total populations of New York and San Fran at the time was only 12 million people. So you're seeing this cancer at 5 times the rate that's normally there. So this was, a clue to public health experts that something odd was happening. And even though, that was back in 1981, the first communities that were really affected it were the homosexual community and minority communities. That was, 35 years ago or so. That pattern still exists today. This is from 2012. If you look at new diagnoses of HIV in just in New York, the people, and you don't have to go through the whole list, basically it's 80% male, about 3/4 black or Hispanic, young, most under 40, and lower socioeconomic strata, looking at 80%. And then also still the gay community. So something that the pattern that was set almost 40 years ago is still true today. And that's, something that really you should think about when you think about why you see certain patterns. I think the only demographic that still has an increasing prevalence of HIV diagnosis is black, I want to say black gay men. That's the only pattern. And again, you can see why that's the case here. Okay, so those were the bad times. What happened here? Why did this all of a sudden just drop off? Almost as sharply as it went up, it went down. What happened? And this is the really cool thing about this, is that this is where public health policy can be a huge benefit to everybody. It can be this was a huge public health win. Did anyone know what happened in the mid-90s that really drove this down? So combination therapy for HIV really helped us, and not just the black community or the Hispanic community, everyone. So it was seen most starkly in the black community and minority communities, but I'll show you here why. So again, you're seeing this graph looking at the rates of death for those black men aged 25 to 44. So if you were dying between if you were young and black and dying in the early to mid 90s, chances are it's because of HIV. But again, look at 1995 or so, when heart or combination therapy became basically standard. It drops off like a rock. So this is just for black men. Let's look at white men, same thing. And look at all groups, men, women, black, white, they all drop off like a rock. Now, but one thing to really see here is that when you're reading graphs, and this is part of the reason why I like teaching this to to people getting into public health policy, it's always important to look at the axes. So here, if you're looking at black and white men, you're still looking at, they drop off. You can clearly see that. But you can see it also that they're still about, at its peak, there was about a 4-fold, almost 5-fold difference between the two. And for women, it was about an 11-fold difference. So you can really see that even though it helped everyone, there was still a huge disparity between these communities. All right, so after that, the line continues to go down, and now we are at a record low, which is good, right? We still have a lot more work to do, but it's encouraging to see that what was a really troubling time for a whole community for over a decade quickly started to right itself and correct itself. And so again, I'd like to finish just by looking at the overall life expectancy. At the extremes, you're looking at black males and white females. In 1970, there was like a 15-year difference between the two life expectancy. 15 years, that's a really long time. For blacks, that's at the time it was like close to a quarter of their lifespan. But despite the fact that there was this drop-off in the mid-80s to 90s, that has gone down to a 10-year difference. So we still have some work to do. There's still a lot of things to go, but it's encouraging that we have made so much progress in a relatively short amount of time. So again, to sort of take home points for all this is that the urban health environment is very complex. There are a lot of structural and environmental factors that can be detrimental to people's health. But with certain policy and legislation, those things can be reversed. Well, first, they can either hurt you a lot, and then if you reverse them, you can actually reverse that. You can reduce that. And the main take-home point, and this is part of the reason why I'm giving this talk here, and I hope to do it in the future, is that increasing public awareness and understanding the scientific advances that are going into medicine and public health can dramatically shift policy and can have a really dramatic effect on life expectancy and entire communities. And that's it.
Hello. I'm glad your last point was about awareness because that's what my question is about. It's kind of twofold, but I'm curious about the diabetes topic more towards the beginning of your conversation. You covered so much, but specifically on the issue of diabetes, and the two examples that you gave were both relating to food. And I think it's fabulous that there were healthy options that were brought into the neighborhoods, but are you aware of what was done to educate the people about the need for the healthy food? Were they wanting this healthy food? And I'm also curious about, so with that question, I want to know if you know what was done with that to address the education and make sure that it was not only available but desired by the people. And if not, if you don't know about it, that's okay. What do you recommend to get people more aware about needing healthier food, and if it's more available for them to actually consume it? And then the other question, you mentioned how it's very expensive for buildings to be created in these urban environments. So speaking on the environmental topic and how there aren't space for children or adults to play, to exercise, and that also is contributing to diabetes. There wasn't anything that you mentioned in those two examples about space and physical activity, which is also extremely important. So what do you propose to increase physical activity and education in these urban environments? I know it's a huge, complex question, but I would just like to know your opinion and something you may have seen be done that you think is successful, something you could recommend to us, something we may be able to implement. Thank you.
It's a lot of questions. So let me just preface this. I'm not a public health expert, but I can give you my opinion on what I think would be helpful. Definitely education is part of it, and it's like anything else, you have to start early. I mean, by the time you're already a teen or getting into your college age, your habits are already set. So starting with kids, starting and going, and I know it sounds kind of hokey, but going to middle schools and elementary schools and emphasizing the importance of a healthy diet. I know that there's more of an emphasis now. They have the NFL has their Play 60 program where they're trying to emphasize getting out 60 minutes of exercise every day. So just making it aware that these are a big, having a big issue, and it is definitely possible. I mean, if you look what happened with smoking, I was told, or I'm sure everyone was told since they're a kid, don't smoke, don't smoke, and you don't even know what smoking is at that age, really, but you just know it's ingrained in your mind. So, I mean, I think having the same sort of effect with exercise and proper diet can probably have the same effect. Hold on, let me just grab these other questions.
Since I'm 5'1". Hello. Two things. Maybe just the one. Could you please give us some insight about the septicemia?
So I'm not sure. I think the septicemia is one of the sequelae of diabetes. I'm guessing here. So septicemia is when you have a wide infection that usually is bloodborne. A lot of times with diabetes, you develop peripheral neuropathy, and that means that you start losing feeling in a lot of your extremities. So a lot of your extremities you can develop sores, and normally if you can feel them, you'd be like, oh wow, there's a sore on my leg, I should protect it. But when you have this damage to your nerves, you don't notice it. And as a result, that can get infected, and over time, that can probably lead to things like septicemia.
So that takes place immedially, or it takes a while?
No, this is chronic. This is
Chronic.
a very, very, very long-term thing.
Thank you. And I don't think it's hokey going into the middle schools. just saying.
Thank you. You do not need a mic, but it's okay. You have it in your hand.
So, no, my question
Yeah.
as you were looking at, as you were looking at some of the environmental factors relating to asthma in certain areas, did you also look at airports and the traffic of the planes? Because I know in Newark, it's a big issue, and some of the land is not even useful, like it can't even be used because
Well,
of the toxins from the.
It may be. I am not sure. I think that probably motor vehicle traffic would probably have more of an effect. Because if you look at JFK, JFK is in the middle of a wetland. There's nothing around it. Like when you fly.
But LaGuardia is not.
LaGuardia is not, but also it's a very self-contained area. I think, and then again, I haven't looked closely into it. I would imagine that just because of the high volume of traffic, and there are 8 million people that live in New York, and many people who work in New York, and a lot of people drive. I would imagine that probably motor vehicle traffic has more of an effect than airplane traffic.
No, I was just curious to know if you
I have no
kind of
idea.
looked at that. No, you didn't. And the last quick question was, as you were looking at the homicide rate, did you also factor in the homicides that did happen in prison, not necessarily just the effect on life expectancy?
Within prison, I didn't really look at, but I would consider that, considering the incarcerated population is such a small proportion of the overall population, that it probably wasn't the in-prison homicides that played a role in that. Sorry. Any more questions? Yeah. One more? Sure.
Yeah, I was just wondering, in looking at the life expectancies, who was dying? You know, are we seeing a lot of young black men dying, and that's like all the people getting out of prison, and that's what's changing the life expectancy? Because it's not, I would be interested to know if all black people are dying 10 years before all white people, or if something's throwing that off. I'm wondering if you were looking at subpopulations, especially by age.
Usually, especially for homicide, it was usually young black males that was playing a key role in it. And for HIV also, like I mentioned, you know, the disparity between the two groups was usually younger black males. Not to say it wasn't affecting other people too, but I think that's the primary population.
I just think, like, when we look at that really amazing statistic, like terribly amazing about jail time versus life expectancy, that you have to guess that a lot of people are probably dying right away, and then some people are living the full amount. So it's kind of, it was, I think, a really helpful statistic, but it could also be misleading.
Right, definitely. And the one thing, if you look at the cause of death, usually immediately afterwards, it's usually overdose or homicide.
Yeah.
So those are the two main things that cause the immediate death after release.
Great, thank you.
No problem. All right, I guess that's all the questions we have. And thank you.